hopefully. All right, so you now know me already. I'm Kasey Boehmer.
And I'm Summer Allen. I am a family medicine clinician. I actually work in this building just down the hallway and have had the pleasure of working with Kasey and many colleagues here in the room for far too many years. I've forgotten at this point. But again, I have really enjoyed the partnership and opportunity. And you all got to hear my perspective as a primary care clinician, where it's a challenge. I guess I would say at times, and not a challenge because we don't want to or I don't want to, but often the constraints, and that's the perspective I sometimes try to give our research colleagues and design colleagues, is what it's like as a clinician. Because again, I think we all can come at it as patients ourselves, but also where we're challenged institutionally, and how do we break down those barriers.
And it's been 8 years.
Kasey knows.
So I actually met Summer as a result of our development of the ICAN Discussion Aid. So
yes.
that started in 2014. And so 8 years.
8 years. Perfect. Thank you.
Yep. So for this workshop, our goals are to discuss unique problems of managing chronic conditions, learn how to use the ICAN Discussion Aid, and distinguish some conversations using ICAN versus maybe current conversations that you usually hear in practice right now. So we're going to start with an activity. You need your first patient case for this. And your task is to read together your first patient case and create a list. You need a list of the tasks that this patient needs to do to care for their health, and also another list of the strengths and challenges that they may bring or that they may face in trying to do these tasks to manage their condition. Now, in the room, you're going to get into pairs. You're physically here. If you are in our virtual world, we're going to put you into breakout rooms of 2 each. And so your task is the same. Read case 1 and list the tasks that the person needs to do. And then the other list is strengths and challenges in doing those tasks.
This individual has a lot of tasks to accomplish to help manage their diabetes, right? They have to administer their insulin, they have to check their blood sugars, there's diet and exercise, there's various appointments that they have to go to. But they face a lot of challenges to carrying out or accomplishing these tasks, right? They have a fear of needles. It's unclear or uncertain the importance they attach to their A1C and how valuable it is to get that down. They have a full-time job, which is short-staffed. There's not a easily reachable, or it's difficult to get to a place to check their blood sugar or administer their insulin. They're not allowed to have food at their desks. Their house is not necessarily the best environment to facilitate some of these tasks like diet and exercise, and they don't have a lot of time off to go to tests and appointments and things like that. So lots of challenges.
Thanks, Mike.
Limited perspective of one person is telling Ian, you know, when I'm in with patients, there's no referee in the room telling me whether I'm doing shared decision making well or not. So I really don't know if I'm doing it, but this is how I would look at this when I look at what she has to do. To me, it looks like she has to work and she has to stay out of the hospital in order to work. And probably wants to control symptoms like peeing and fatigue, and she has to maintain her home. And those are the things that I would look at are the things that are the challenges. Managing, that's helping her. Taking care of her diabetes, which is a secondary issue to me, not knowing the severity of her disease, would be, okay, there are ideas about taking insulin and shots and how many blood sticks and how to get rid of the industrial waste, and some ideas about exercise and diet and some ideas about appointments, but it doesn't sound like any of those really are realistic. So my approach would be to say, to validate, it sounds like you really need to work, and we can help you keep your job and stay out of the hospital. And here's some ideas on how we can try to give you a simple, feasible plan. And what do you think about it? All the other stuff with the shots and the needles and the visits is negotiable, in my opinion. And if you got 2 days off a year for this, we'll group as much of that on those 2 days as we can and try not to interfere. And then we're here in between. I don't know if that's shared decision making or not. I just know that that's what I can get done in 15 minutes, which is what I have.
Yeah. So there's a lot to hold on to and try to make sense of, and then wrap your hands, heart, head around pulling that together for a patient.
One thing she doesn't have to do is come back and see me again. And I know that because if I make the plan, she's going to go somewhere else. We're just not come back. And that's the last thing I want. I want to make sure she doesn't just give up, because I don't think we measure those people. They don't show up.
Yeah. The invisible. The system. Anybody else want to share? Keep going.
Make sure that as you share, you, particularly the people in the room, introduce yourselves, say your name so that folks online can follow, because they only hear a voice, might see a face, but they don't know who you are.
Yeah, that's actually a great idea for both online and in person. So if you are talking, just make sure you're sharing your name and who you are and maybe where you're at in the world. And that way we can get to know each other a bit better throughout the meeting.
I was and still am Mark McConnell. I'm an internist. I'm sitting in the room, but I practice about an hour from here.
Thank you, Mark. Appreciate that. All right.
This is
So
Wilma.
let's-
Oh, sorry, I didn't have my hand up.
Hi, Wilma.
Hi, I just had a quick comment. So I'm from London, Ontario, Canada, and I'm a nurse practitioner working in chronic diseases. First time here, so thank you. And what I was interested in terms of follow up to the last comment was, I agree the patient has a lot of work. But what's interesting, in the 15 minutes, getting this story and making a plan would almost be impossible. We already have the perfect story, but getting that story is going to take you a long time, and it's probably going to take you a lot of visits. So that's sort of one caveat, I think, to this case, that in real life, you're not going to get this story as complete as it is.
I think that's a great point. Let's hold all of that a little bit in our heads here, and then slides again. So the patient case that you read is a human story. And oftentimes what we hear about when we are discussing patients living with chronic illness is the number or the amount of patients living with these chronic conditions. And this particular graph shows us the growing wave of chronic conditions, which by working age, late working age individuals, already a third of them have multiple chronic conditions. So they likely are holding and juggling these many things for their healthcare as well as their lives. But I think it's really important to focus back on what we learned in the case. This is a human. This is a human life and a human story. And it is not as simple as what we can display on a very nice, pretty graph such as this. Now, our team published this paper back in 2012, so 10 years ago. that outlined what was called the cumulative complexity model. And this model still to this day underpins much of our work. And I want you to think about it and reflect on it as you think about what you just discussed with Claire's case. So patients have the work of being a patient, but they also have the work of their lives, which many of you commented on during that case. They have a limited amount of capacity to take that work on, and that capacity can be influenced or reduced by scarcity in their environment. So these could be things like environmental or socioeconomic challenges that the patient faces, as well as their burden of illness. So whether or not you live with chronic conditions, you know when you are sick and you don't feel well, you have less capacity to do the things you need to do in life. That balance affects patients' abilities to access and use healthcare and enact their self-care at home, which logically, as clinicians, know this affects their outcomes. The challenges in the healthcare environment that we currently work in is that we typically only see the outcomes. We see the numerical input of A1C or any other health disease outcome that you might see. We do not get a feedback loop in the healthcare setting of workload capacity imbalance. And that actually may be the driver of worsening outcomes for many patients. If we respond to those worsening outcomes when the problem is back here with more treatment, we increase the burden of treatment while the patient continues to feel worse because now they have a care plan that is even more infeasible for them to work on in their lives. And these are other factors that influence the burden of treatment as well. Poor care coordination. If you have multiple chronic conditions, who knows what you should prioritize? Maybe the healthcare system isn't actually working with you to prioritize what's most important based on your goals. We measure by single disease targets. That's going to add additional work for patients. So all of these things continue to contribute to the burden of treatment. Now, our team and others around the world have been working on trying to understand better what is the work of being a patient? What are patients asked to do? And one of our colleagues who spent time in the care unit did a study, a real-time study of patients in their lives, what they were spending to manage their health, particularly around diabetes care. And on average, they were spending 9 minutes on medications, 5 minutes on monitoring, and 30 minutes on health activities. And so this is a daily picture of what people are doing, and that's for a single chronic condition. We also know from our colleagues that 40% of patients report that they have unsustainable treatment burden. So if they had to continue to carry out the care plan that they have, they would not be able to sustain it for a longer period of time. You want to comment on that at all from a clinician perspective, Summer?
A couple things come to mind, but one that I think about often is this idea a little bit too that health, and Dr. Kuhlman talked about it, Marlene, of choice or chance too, right? We are instilling these treatment options or providing these things on this chance or choice of health, right? It's this promise that we're giving patients. If you do these things, you'll live longer. They could get hit by a car the next day. They could get diagnosed with metastatic cancer the next day that kills them or have a heart attack, right? It's these chances, and I think it's a challenge sometimes as clinicians. I think it's a challenge for people to understand that those things don't provide the same gratification until there's something that someone's living with. I often in primary care, again, I am promising them health or trying to give them this chance of health by if they do all these things, when there are other things that they can spend their time, their energy, their capacity on that provide them much more instant gratification, instant result, instant promise that health is not a guarantee on. So that's what stands out to me when I think about, again, a sustainable treatment for people. We have to understand too that they're balancing it with things that bring them far greater joy or bring them far greater interest in their life than their health.
Exactly. Okay. So now we're going to give you the opportunity to play with another case. And this time, one of you is going to take on the persona of case number 2. And the other one of you is going to play clinician in this scenario. And just try to have a conversation. So try to understand the same things that you were picking out in that case together. Try to understand those and try to learn from the patient those things in conversation. So you are coming into this without any knowledge of who this person is or what makes them tick, and you need to learn that information in a quick manner for a clinical conversation.
So in our group, we talked about how perhaps we needed to start over from a clean slate and sort of get a good understanding of what he understands, because he's quite articulate, recognizes that, he's not great to live with. So what's his wife sort of said to him? What kinds of things can we help with there?
Oh, you muted Wilma on accident.
To think about what.
Oh, it happened again.
What things are important to him and what he would like us to try. And so this was not going to be a 15-minute appointment exactly, but perhaps a starting point, and have iterative appointments and sort of trying to work with him so that he does actually have better quality of life with pain. We did have a pain specialist in our group. She might want to sort of add in.
That'd be me. Hi, I'm Ruth. I'm in Australia. It's 1 a.m. right now. So I'm keen to be here.
Rock star.
So just to really, I guess one thing I noticed as a pain clinician is that one of the big issues with persistent pain is that diagnostic uncertainty, and really so much of pain is driven by social and emotional sort of environmental factors, and he's certainly got a lot of factors which are likely to be driving to his pain. And so really exploring with him, or trying to sort of validate that diagnostic uncertainty, and really exploring the pain as a series of contributors rather than a nice, clearly defined diagnosis. And in some ways, he's already got that idea, because he's identified how his emotions interact with his pain, whereas it sort of sounds like his doctor, who's just giving him medication, doesn't have a concept of that, is still sort of approaching it in a biomedical way, whereas Todd sort of maybe is already partly the way there. So certainly validating his experience and exploring those contributors with him, I think would be really important.
Awesome. Thank you for sharing. How about our in-person folks? Reflections on that activity?
For example, Derek was acting as a clinician, and one of the things he said at the beginning was that he's trained in psychologist. So I was wondering, how a clinician, have maybe lack of skills on more psychological issues, And I felt like Ted was more needing like someone to listen him and more maybe suggesting more, I don't know, strategies to better talk with their family, let them know how he's feeling with all his, like all the pain he's going through. And so, yeah, we were like discussing how challenging sometimes for clinicians that are more focused on like a clinical perspective to be empathic and kind of be responsive to those kind of more psychological situations.
Yeah. So, Camilla, did you want to share something?
I'm Camilla. I'm a research trainee here in the unit. And we could feel as well like the patient is kind of like frustrated because he tried to get help from other like physicians. And I feel like we're focused on trying to get like a diagnosis and like, oh, some pills here is your solution. And maybe it's much more than only this. This is not like what the patients need. So like reflect about it.
So you guys are all bringing up issues, I think, from a clinical perspective that we were considering when we started to develop the ICAN Discussion Aid. So start screen sharing again. Sorry guys, my presentation went away. So not only did we have the cumulative complexity model, that diagram I showed at the beginning, but we had a lot of also detailed knowledge about both capacity, what makes capacity and what makes treatment burden. So briefly, this is the theory of patient capacity our team developed, and we developed it through a very large systematic review. I think it was 141 qualitative studies that we did thematic analysis on. And what we found that made up patients' capacity was, first and foremost, their story. So who they are and what they do in the world, their biography, it matters to people. That really is something that is close to home to everyone. And chronic illness fundamentally disrupts your biography. So you are who you are, and then you have a diagnosis and you have to renegotiate that biography. And some people, that happens very quickly. They do it very well. And for some patients, they get stuck in this reframing. And so it's really important to understand who people are and what matters to them. We also noticed that resources matter. So we think about resources as financial resources, transportation, but also things like self-efficacy and health literacy are involved in resources. And then there's the social functioning of that group. So who is in their social network? How do they support them? And then the realization of work generates capacity, which might seem a little counterintuitive, but what we found was that if patients had small pieces of healthcare work that they actually were able to accomplish and feel that win of accomplishing that in their busy lives, that perpetuated additional capacity to do more. And this, of course, all is in the context of the environment. So that's their home, their work environments, as well as their healthcare environment. So when they come into the healthcare environment, do they feel supported as who they are and what they want to do in the world and what their condition means for them? Or are they met with disbelief and siloing into places of care? The other thing, which is even a much more detailed and overwhelming piece, and you obviously cannot read all of these, but this is a taxonomy of all of the factors of patients' burden of treatment. And so if you zoom in each of these little tiny areas, there's these very important things like coping with judgment from others in my professional life with chronic illness. But we can't really talk about this big, massive web of burden of treatment or these big pieces of capacity in a single encounter. And so how do we capture and start to make meaning of those things together? And that's where ICAN came in. Summer, you want to share any of that from your perspective?
I'm gonna let you. I have some thoughts, but I was gonna let us do
Okay.
our other activities before.
Okay, sounds good.
So I don't ruin the activity.
Okay. She doesn't want to give any spoilers. So what I want you to think about is that care of people living with multiple chronic conditions is not only a complex situation, but it's actually kind of ambiguous. What matters, what to do with all of these pieces? How are we going to uncover them? And Dr. Hargraves, who I think is over there, has noted that there are two communicative strategies when dealing with this ambiguity. And the one most commonly used in healthcare is that we define something, we assess it, we interpret it, we diagnose it, we try to get it in its nice little box and figure out what to do with it from there. But there's another option, which is to make that ambiguity productive for the people involved. So life is naturally messy, and when you throw in chronic conditions, it's even more so. But can we have conversations and communicate about inventing solutions, making meaning in life, even in challenging situations? And so there's two, if you look at the final version of ICAN, it says, my life, my healthcare. These are two ambiguous terms, but if we start to talk about them together, potentially we have the opportunity to make meaning and move in conversations towards understanding what these mean for each unique person. And to give you one example, which is still my favorite of all of the ICAN encounters that we watched, was a woman from Minnesota where we have a lot of snow. And she was in with her primary care clinician, and they had ICAN together. And she was discussing potential solutions for bladder prolapse and pelvic organ prolapse. And her clinician had previously offered surgery, but she really thought she did not want surgery. But through this conversation, through this meaning making, she started to talk about how much she loved to shovel snow. And you're like, who on earth, why? But her meaning behind that was that the way she got through Minnesota winters was to attack it. And her ability to shovel snow meant she was able to attack winter. And so when they started to talk about this and realizing that surgery might get her back to being able to shoveling snow, which she was no longer able to do, that started to become a much more viable and attractive option for her if that was what it was going to mean for her. So the final tool, and there were 10 previous versions to this, to the one that you have in front of you now. But the basic idea behind it is, on the left, we talk about areas of your life. Are they a satisfaction, a burden, or both? And on the right side, what are the things that you've been asked to do to care for your health? And do you feel that those are a help, a burden, or both? So loosely, this is related, the left is related to capacity and the right is related to potential treatment burden. We also have 3 questions on the back that are, well, some of them came from the original development and then some additional ones were added from our partners in Arizona who have actually used this the most. They have a clinician there who's, I think, used over 1,000 ICANs and collected and synthesized them. So these are the final 3 questions that are there. And the way that it works in conversation is the patient has this filled out, and the patient and the clinician get to review it together. And the clinician starts the conversation with what stands out to you from what you filled. So all of this is really ambiguous, but what is meaningful to you? What stands out to you from what you filled? And sometimes you'll hear things related to people's lives. So maybe they're moving towards retirement. So they're having a big transition towards retirement, and that's really going on in their lives, and it's having a big impact. But maybe they start talking about they have 15 different pills, and some need to be taken without food and some need to be taken with food, and they literally cannot figure out how to reasonably implement that in their lives. So this is where Summer was saving you from spoiler alerts. You're going to have the opportunity to play around with ICAN. So you first need to fill one out. You can fill one out as yourself, or you can create a patient that maybe you've met before, or you can use Claire or Todd's case scenario. I'll put you back in your groups, your pairs again, and you need to decide who will play patient first. If we have time, we'll let you play both, but if not, we'll move on. So you got to pick who's going to be your main patient. And then you're going to start using the tool. You're going to ask what stands out to you from what you filled. Review the inside, review the questions on the back with the patient, and see where it gets you. Okay? It's not going to be perfect, but it's meant to be an opportunity to try it out. Nico, I haven't heard from you. Were you playing clinician or were you playing patient?
See, I told you, you get called on.
So it got a little ambiguous as we went, because then we were both sort of, it started me as a clinician and Chris as the patient, but then we both were trying to give different views about it. And I think basically with the tool, it helps much more to have a road towards what's going on in the patient's life, because you need to have a picture of what's going on and what the values are possibly that the patient wants to work on to take it from there. Because one of the things we're mentioning is that it's our values that sometimes we are transmitting into the patient. What we would like to have in our lives in that position, we would assume that maybe the patient, that's what he would want, but that's not true. So I think we mostly agree that communication is essential to understand what's going on in the patient's life.
Thank you for sharing. Online? Anyone? Oh, I see Anne. Anne's got her hand up. You're muted, Anne.
Okay, got it. Sorry, this is the first time I've done Zoom, so.
We're all learning as we go, Anne.
Yeah, as a clinician, I think this is a great tool. It's the first time I've seen this, heard of it. I work with VA patients who have multiple conditions. And so I think this is going to be very helpful also to gain insight into what's important and what to prioritize, and start conversations about these areas that are burdensome, and looking at ways to maybe change that to an area of satisfaction. It's a lot of different categories, but I think it's a place to start, and I'm glad to know about this tool.
Awesome, thank you. Sarah is sharing some poetry in the chat for us, so we can reflect on that. I need to have an offline conversation with you now, Sarah. Summer, you had some thoughts before we show the last few slides?
Sorry. Trying to, again, capture the different comments and questions. So From a clinician perspective, and as you utilize the tools, I think the highlighted point of the psychology sometimes, right? Like, is that our role as a psychologist? Or gosh, how do we talk about finances and both Kasey and Ian will remember vividly that I told them my greatest challenge of this tool, or which I loved, but was also identifying things that I had no ability to influence and that I had limited ability to control. What I remember that is I'm not a financial advisor, right? Like when it comes to housing, I can understand it that they may not have adequate housing. How do I help them with it? Some of the medication challenges are this. A lot of knowledge. I can look it up. But again, as some of the clinicians in the group have spoken to, you're given a 15-minute visit. So how do you leverage, and what made me think of was pushing toward a little bit of what JP was saying earlier to Marlene, the focus so much of shared decision-making, or sometimes the tools are between a clinician and a patient. How do we expand that not only to the patient's surrounding environment, to their loved ones, to their community? Sorry about that. But also, how do we expand into the network that exists as a healthcare team? Right. So how can the information shared here leverage with a pharmacist that may meet with them, or to someone that may offer capacity coaching? So for those that are participating in the Saturday workshop, you'll get more experience with this tool and some of our colleagues who do capacity coaching with patients. So we have to leverage those tools in order to support patients. The other was the part. Oh, so the other part that I wanted to highlight was the two things about our other challenges: how healthcare has been taught for a number of centuries, and or trained current clinicians and still trains future clinicians, is very much in how Kasey shared. Ian is described and kind of define, assess what's my diagnosis and what's my treatment. And it exists a little bit, I think, sometimes in uncertainty or ambiguity, but a lot of times patients are coming to us in healthcare for what's my answer, right? What's going on? And we may not have that. And we have struggled to train clinicians how to have those conversations or how to support patients in it. And one of my favorites, which did not make it on those questions on the back, but I encourage people who are in situations to have conversations like this with patients, was I asked one of my patients one time, what does health mean to you? And right away she said, well, that my A1C is under control. Or another patient that I brought it up to, oh, that my blood pressure is under control. And I thanked them. They did an excellent job at defining healthcare how I had defined it, right? And how medicine had defined healthcare. But I said, what does it mean to you? And what I found very interesting, and think is also a continued challenge right now, is patients are never asked that, right? They don't come into the situation with people being curious about that or wanting to understand what this looks like. So it's a challenge for them as well. I mean, some of them sat and it was that uncomfortable silence for a while to think about, well, what do you mean? No one's ever asked me what that looks like, but it gets to the, I love shoveling snow, or I want to be able to go to work, or I need to be able to provide for my family. So asking that question really does help open doors. So that was my
Awesome
input.
Thank you for sharing, Summer. So I'm going to wrap us up with what ultimately was a bit of a last minute addition, because it literally became live, I think maybe a week ago. So one of the big challenges that we have had in implementing the ICAN Discussion Aid has been the ability to track it over time and somehow store the information with a paper-based tool. So the paper-based tool is great for creating conversations, but when you start trying to conduct research with it, or you start trying to keep track of what your patients have said over time, if you are a clinician who's using this regularly with your patients, maybe every 3 to 6 months, there's no way to track changes on the paper version. So
The only other part I'm gonna say too that I love about this is you can share this with other healthcare team members, which is also
yes,
the paper form is difficult to share.
So inside of this is inside of Mayo. So if you are a system outside of Mayo, I think there's opportunities for collaboration around this. But we do have it in the medical record now. So it can be distributed through our patient online services. So patients can get this to their portal ahead of a visit, or they can do it on a tablet now ahead of a visit. This is just a slight zoom in of where that is. And there's a pop out on this that says add questionnaire. It's favorited in this view, so it doesn't show it exactly. You can also send it through an in-basket message to your patients. So if you want to have a custom, kind of email greeting with it, you can also do it through the new patient message as well. So it can connect to a visit, or it can be standalone. And when you go in to add that questionnaire, all you have to do now is start typing my life, my healthcare, and this will pop up as a questionnaire. Now on the patient's—
Doesn't autocomplete to my life sucks or something like that.
No. It will only say my life, my healthcare.
For me, that does.
So from the patient's end, what they will see is they'll actually see those 3 questions first, and then they'll see, are these areas of your life a source of satisfaction, burden, or both? And then next you'll have what are the things that your doctor has asked you to do to care for your health? Are they help, a burden, or both? And what's lovely about this is it's tracked in a flow sheet. So you can see answers to any of these questions whenever they have been filled out. So you can track those over time, and you can see if something that has been a burden, maybe through working together, shifts over, or maybe you get a signal that, this patient is struggling because a whole bunch of things that were helpful or satisfying are now not that way. And so that can also be a point of conversation. So much more to come on that. That was a long time coming. I think it was our 3rd attempt at getting it in the electronic medical record that we succeeded in doing. So I think that there will be a lot of additional research and potential to partner on that in other organizations as well. So with this, I just want to highlight this is really designed to create meaningful conversations. And as Summer mentioned, there will be other ICAN sessions. And we do use ICAN as the basis for capacity coaching, which is our focus of our Saturday program. So more opportunity to come to get to experience this. If you would like to look at the implementation toolkit, which is designed both if you're a clinician who wants to learn more and implement this in your practice, or if you are part of a healthcare system that wants to think about how do you actually embed this in the workflow, we have crowdsourced and synthesized all of that information into the implementation toolkit here. And our contact information is displayed on the screen. So thank you, everyone.